with that, I have 1 p.m. on my clock, and I'm delighted to welcome everybody to this webinar to close out the NAMI Montana conference and webinar season. And we really wanted to do this because when we have psychiatrists in our state and providers in our state that have risen above and beyond to share with the public and do amazing things over and over. NAMI Montana knows that you pay a lot of attention when those people are excited about a certain thing, when they're doing a certain thing. And because we all need to know, and we all need to know what they're thinking and be able to see how to tie it in to the folks we are helping navigate for care, our families, our loved ones. So when Dr. Heather Zaluski told me about this model that she was working on, this initiative, a new branch of her career, but even something bigger than that, I was excited and immediately was like, okay, we're doing a December webinar just so people can hear about this. And I will say, having tried to recently placed somebody with a child psychiatrist, this could not be any more timely. So I just want to say, I'm sorry for the time mix-up, but we're so grateful to have Dr. Heather Zaluski in Montana, partnering with us for years and years, and delighted to have her share it today. Thank you so much for being here, Dr. Zaluski.
Yes, it's really, truly my pleasure, Matt. Thank you so much for having me today. I'm really excited to share with all of you about this project that I've initiated this fall. I am calling it the Pediatric Partnership Project. That's just kind of a name that I made up. So it's not, anything official, but that's the essence of what I want to do. Is I want to partner with pediatricians, pediatric nurse practitioners, family docs, people in primary care who are seeing the children in our state and help them to provide higher quality mental health care to Montana's children. So with that, I wanted to start out with sharing a little bit about me. So I was born and raised in Michigan, so I am not a native Montanan, but hopefully we can all kind of get past that. I have been living here since 2007, so spent quite a bit of my adult life here. I did all of my training and education at Michigan State, so I am a Spartan. Graduated from there in 2002 and went to University of North Carolina in Chapel Hill, so I'm also a Tar Heel. Can't say I love Duke. And so I trained there 5 years, and then after completing my child and adolescent psychiatry training, moved to Montana with my family. I've been living here, working here since then. I went directly from training to Shodera Children's Hospital, and I was there from 2007 until 2022, so 15 years. And I was medical director starting in December 2019 through the end of June 2022. So you can imagine that was a little bit of a wild ride. Then I spent a year with the Rural Behavioral Health Institute. I was their medical director starting in July of 2022 through this August. And then since then, I've been working on launching this initiative. And then outside of my professional life, I enjoy travel, cooking, swimming, snorkeling, birding, rock hounding, quilting, a lot of hobbies, and of course, spending time with my husband, Marty, and our 3 kids. So that's a little bit about me. Wanted to outline this presentation for you. So we'll start with the why, right? You always want to start with why. Why am I doing this? And I know that perhaps some of you on the call are here because you haven't done your suicide prevention CE yet for the year. And so I will be connecting this project to suicide prevention in Montana. I'll share some of the healthcare models that contributed to the project design. I did not just start from scratch with this. I did use some of the existing models that are out in the healthcare world. as well as I'll share some other concepts that are more loosely related, but did inform my thinking on the project, including the catcher in the rye, upstream and downstream public health concept, and the school system response to intervention, or RTI model. I'll also talk about the current versus ideal structure for treating children with mental health issues in terms of matching complexity of cases with level of training for people who are prescribing medications. And that in this whole presentation, and the focus is on medication interventions. I know there are many, many other interventions for mental illness and to promote mental health in children, and those are extremely valuable, of course, but my focus today will be on medication interventions. I'll talk about project goals, project structure, how to refer, and then I will take questions. So what is the connection of this presentation to suicide prevention? So this is not, I'm not going to be teaching you a new therapeutic technique or educating you on a gatekeeper intervention or giving detailed statistics on Montana's suicide crisis. I will touch on that, but I don't have all of the numbers and percentages at my fingertips. I would encourage you to look at the excellent state website if you would like that information. But the purpose of this presentation is to describe why we need a novel approach, explain several existing models that contributed to the new approach, share relevant concepts from other fields, describe the project goals, workflow, and referral process. And really, I would love to partner with all of you in this project with the goal of improving the quality of children's mental health care in Montana and thus reducing youth suicide. So let's talk a little bit about the scope of the problem. Why do we need this? Why do we need a novel approach to mental health care for children in Montana? We know that Montana has some of the highest suicide rates in the country. And we know that included in that are very concerning suicide rates for youth, as well as very concerning depression rates for youth in Montana. We know that depression is a main risk factor for suicide. And so that does lead us to, many children in Montana needing mental health care. And unfortunately, there is an extreme shortage of child psychiatrists in Montana. So there's not nearly enough child psychiatrists to treat all of these children that have depression and are at risk for suicide. So really what we need is a way to bring child psychiatric expertise to more children. I'll talk a minute about why I'm doing this. First of all, I just really care about kids. I'm the mother of 3 children, and I've been a child psychiatrist for over 16 years. Suicide prevention has a really special place in my heart within that field, or within the scope of caring about kids, on both a personal and professional level. I did lose my mother to suicide when I was 14. And I have a child who struggled with depression and suicidal thoughts. So it is a very personal thing for me. And then obviously I've devoted years of my life to training to be a child psychiatrist. And really one of my core missions in that field is to help prevent youth from committing suicide. I care a lot about Montana. I've been here since 2007, and my husband actually has even deeper roots. He's a Butte High grad. So a lot of connections to Montana, and plan to be here for the remainder of my career. I was at Chaudière for 15 years, and that was very gratifying clinical work. I worked with some of the sickest kids in the state, worked with excellent clinicians. I love the team-based approach. But towards the end of my time there, I really realized that no matter how good of a child psychiatrist I am, if I'm just treating patients one-on-one, I'm never really going to make an impact on the broader issue of Montana's suicide crisis. And so I really, when I left Chaudière, I wanted to impact children's mental health in Montana at a broader level. So these are just a couple of the suicide statistics. This is from, these are some recent news articles. So in September, the Bozeman Daily Chronicle reported that although in 2021, Wyoming had the highest rate of suicide, it appears that we took the spot for 2022 in leading the country in the rate of suicide. Not something to be proud of. And again, another reporting this time from Montana Public Radio in August of this year, that in recent years, Montana has seen one of the largest increases in suicide nationally, a 42% increase from 2011 to 2021. So we were already not doing well, and it appears that we're doing a lot worse. So that is concerning. It does appear that there's a link to firearm possession. And certainly I am not here, and I do not advocate, no guns in the home, or I'm not anti-firearm. What I am passionate about is safe storage. So that is something that I talk about with every family that I work with, is the safe storage of their firearms to prevent a tragedy. So let's just look a little bit at youth suicide and depression statistics. So the CDC does surveys nationally. It's called the Youth Risk Behavior Survey. And the most recent year that we have data for is 2021. And looking at high school age youth in Montana, almost half the students reported significant depression symptoms. It was over 40%. Roughly 1 in 4 reported seriously considering suicide. About 1 in 5 made a suicide plan, and then 1 in 10 made an actual suicide attempt. And then, more sobering news, the rates were even higher for some groups, particularly female students and LGBTQ plus students. They did a 10-year retrospective from 2011 through 2021. And looking at all of those mental health data markers, so depression, suicidal ideation, suicide plan, suicide attempt, every single marker was headed in the wrong direction. And all of that data and all those numbers are available at the CDC website, which is on this slide. Looking at that, actually, interestingly, even though Montana does typically stand out as being a leader in the country, so to speak, in terms of suicide, if you look at US versus Montana data in 2021, the numbers are the same, or for depression, the rate broadly in the US was just a touch higher. I believe it was like 41 versus 42% for United States data versus Montana data. So actually in 2021, which I really don't think this is good news, but Montana didn't really stand out as having higher rates than what we're seeing on a national level. And then, I think it makes sense logically that depression is a risk factor for youth suicide or for suicide in general, but I decided, rather than just like taking that for granted, that I would look at some research and see what research showed. And so this is an article that is available online at the NIH website. And that most studies agree that suicide is closely linked to mental disorders, and that about 90% of people who commit suicide have suffered from at least one mental disorder. Mental disorders are found to contribute between 47 and 74% of suicide risk. Affective disorder is the disorder most frequently found. Criteria for depression were found in about 50 to 65% of suicide cases. And again, unfortunately, more often among females than males. So although I think that males have a higher rate of suicide death, obviously there's a lot to be concerned about with our girls. So let's just kind of look at that data, and let's kind of pencil out from there how many kids in Montana need mental health help. Okay, so I just did a little napkin math here. So I looked at the OPI website, and I found that there are, in 2021, 2022, there were 68,288 middle and high school students in Montana in our public school systems. So let's just round up to 70,000. And if we say half have experienced depression, then that's 35,000. 1 in 5 made a suicide plan, 14,000. 1 in 10 made an attempt, 7,000. So then let's think about which of these students need to see a child psychiatrist. And let's just say that we're just going to say that the students that have actually attempted suicide need child psychiatric help. Okay, so that's 7,000. Of course, making this assumption leaves a huge number of kids not seen, right? Any kids that are younger than middle school, any kids that don't meet that really very high criteria, and any kid with any other diagnosis, but just to kind of do a little hypothetical here. And then if we look at the average caseload of a child psychiatrist, I mean, there's a lot of variability there, but based on my experience as medical director and doing some research, 200 patients is actually a little bit on the high side, but we're just going to say 200 patients. So that means we would need 35 child psychiatrists just to see this group, just to see these middle and high school students who have attempted suicide in the past year. So now let's look at how many child psychiatrists we actually have in Montana. And this information is from the ACAP website. So ACAP, American Academy of Child and Adolescent Psychiatry, that is our professional organization. So they publish this data. They look nationally, and I'll show that information next, at child psychiatrists and population. And they do by state, how many child psychiatrists do you have? So for Montana, and this is, I believe, 2021 data, there are 24 total child psychiatrists. And that number, to be honest, and I'm also involved in in both national ACAP, I'm a co-chair for the inpatient committee, and then our state chapter, I'm a past president. So I'm very involved in ACAP, and especially from working at Shodera and being medical director, I had connections and relationships with most of the child psychiatrists in the state. And I would say that has been fairly steady the whole time I've been here. We've been hovering in the mid-20s. So and I've been here over 15 years, so I'm not thinking that's going to change dramatically. And then if you look at the number of children under 18, then the number of child and adolescent psychiatrists per 100,000 in Montana is 11. And then the other somewhat concerning statistic is the average age of child psychiatrists, which is 55. And then if you look at these maps, so Montana is a state that is considered a severe shortage state for child psychiatrists. And then this map over here shows the counties. It's a county by county breakdown. Red means there's no child psychiatrists. So you see that is the vast majority of the state. And then it goes orange, high, severe shortage, yellow, high shortage. The sole county that is green and says mostly sufficient supply, that is Jefferson County. And I'm pretty confident the reason for that is that the population of Jefferson County is not very high. And that is a lot of the child psychiatrists, including myself for 13 years, that work at Shodera Children's Hospital live in Montana City, which is in Jefferson County. So I think that's why Jefferson County looks good, but I don't think it actually reflects availability of child psychiatrists in that county. So in the US, so how's the US doing? And again, kind of similar to suicide and depression statistics, not much better. You can see most of the country is considered severe shortage. The rest of it's high shortage. And if you look county by county, there's a lot of red out there. There's a lot of orange, not a lot of yellow or green. So it is concerning. And you can see the average number of child psychiatrists per 100,000 children nationally is 14. So Montana was 11. Nationally, it's 14. That's not much better. It's also considered severe shortage. And again, average age, a little younger, 52, but still not great. So we can hope that more medical students, residents are going into child psychiatry, but that is not a pipeline that's going to just open up and pour a million child psychiatrists into the nation or into Montana. So again, this data is from ACAP. You can see up in the upper right-hand corner, American Academy of Child and Adolescent Psychiatry. Okay, so let's just do a little reality check here. Frankly, there will never be enough child psychiatrists to meet the mental health needs of children in this state. So rather than just, putting our head in our hands like this poor overworked doctor here and, moaning about that and groaning and grumbling, like what can we do? What can we do from a population or a public health approach that will elevate the quality of mental health care in Montana with the workforce that we have? So that was kind of what I was pondering. And there are, as I was thinking about things, there were several models that contributed to my thinking. So the first one was the collaborative care model. Last year when I was with RVHI, I did bridge psychiatric care. So I wanted to incorporate elements of that because that had a lot of positives. And then there's also a national model, Project ECHO, or states have what are called pediatric psychiatry access lines. And so in Montana, that was called MapNet, or that is called MapNet. So Montana Access to Pediatric Psychiatry Network. And so that's another model or kind of initiative that I looked at and incorporated when I was coming up with this approach. So collaborative care. Hopefully this is not a brand new concept to most people, but it might be. So basically, it's a model that was developed at the University of Washington, and the AIM Center, and the website is right there, is the center that really is kind of the center for this nationally. So, it is a regional, started out in Washington and has grown from there. It's been around for decades. There is a lot of research that supports this model in terms of patients getting better faster and clinicians being more supported. So the basic model is that you have this triangle of clinical care. So you have the primary care provider who has direct contact and lots of contact with a behavioral health care manager. That behavioral health care manager also manages a registry of the patients in the practice and consults with the psychiatrist. The patient will have contact with the care manager and their primary care provider. The psychiatric consultant would only have very infrequent or typically the model is not based on the psychiatric consultant having really much contact with the primary care provider and not doing direct patient care. There is a practice in New Hampshire that I was introduced to last year that is doing integrated behavioral health or collaborative care. Those are kind of used interchangeably, even though I'm sure there's some differences if you really get kind of technical about it, but we're not going to get that technical today. So this practice kind of adopted the collaborative care model, but for pediatrics. And so they really felt that the educational professionals, so the school system, should be part of this care team. So they incorporated educational professionals into their model. They also partner with Mira, which is a software company that specializes in measurement-based care. And it's been a very successful initiative. And there is an article in the Psychiatric Times that talks about it if you want to read more about what Mira and Aloft are doing. So let's talk about Montana. That's great for the kids in New Hampshire, but what's happening in Montana? So the Montana Healthcare Foundation is their mission is to bring collaborative care or integrated behavioral health to Montana primary care providers. They have grants, they have support, they have training programs to clinics and hospital systems, and they have helped to launch integrated behavioral health in one private pediatric clinic in Montana, which is the Children's Clinic of Billings. That program started a year ago. They hired a psychiatric nurse practitioner, and they are now in the process of adding a therapist and a care manager. I know both the clinic manager and the nurse practitioner there very well, and had a lot of communication with them. And according to them, it's been very successful. The clinicians, the pediatricians there are feeling much less burned out, and the kids are seeing a psychiatric specialist, and overall it's going very well. So that is really promising, but keep in mind that Children's Clinic of Billings is the only independent pediatric practice in Montana using this model, and there are many other independent pediatric practices in the state. So you probably are wondering, right? Like, why is collaborative care not being implemented more broadly? Like, it sounds great. Why isn't everybody doing it? Well, it does require significant investment, especially at the start. It's going to take time, it's going to cost money, and leadership has to be very committed. This is a different workflow. It's a pretty major shift from the mindset of the typical clinical practice. As the AIM Center website itself says, collaborative care necessitates a practice change on multiple levels and is nothing short of a new way to practice medicine. frankly, that can be a hard sell for busy clinicians as well as for administration who's already feeling strapped financially. So then another model that I drew from was, and my personal experience with RBHI as medical director there, and helped to roll out their program, which is Screening Linked to Care. That's their primary initiative. And then, which is school-based screening of Montana middle and high school students using digital versions of the Columbia Suicide Severity Rating Scale, PHQ-9 and GAD-7. As part of that program, Bridge Psychiatric Care is introduced in spring of 2023. And so that model, I would see kids for a comprehensive psychiatric evaluation if they were flagged in the screening. I would initiate medication if that was indicated. I would follow them until the child was stable, and then I would refer them to primary care or a psychiatric provider in the community. And so I saw about 50 patients as part of that program, and really they were the clinical results were really excellent. I tracked PHQ-9 GAD-7 scores throughout that time and throughout that program, and they dropped by nearly half, really about 45% in roughly 2 months of treatment. So kids really did get better. It was very gratifying. However, that model has limitations. The only way to access it is through the Screening Linked to Care. And so because of this, it's limited to the kids that participate in the screenings. Those screenings only happen 1 to 2 times per school year, and obviously they only happen in middle and high school. And kids can only be referred if they are flagged in the screening. And so then only if they present with one of the conditions being screened. There are occasional exceptions to this, but that's the way the model is set up. So you can imagine that with that model, you end up missing quite a few kids. So those are the limitations. So another existing model that I kind of looked at and took into consideration when I was building this model is the Project ECHO, or like I said, the Montana Access to Pediatric Psychiatry Network. So it's a national model funded by federal HRSA grants. There are many states in which this has been implemented successfully. It's considered a hub and spoke model, with the idea the hub is the specialist team, and they spread their expertise to rural areas and to primary care team physicians and teams, and that ends up then, resulting in better care for more patients. And there are basically 3 aspects to this project. So there's the access line, the Pediatric Psychiatry Access Line. There's Project ECHO, which is like a lecture-based educational component, and then there is an annual conference. So unfortunately, this started in Montana in 2018, and it was with partnership, with Billings Clinic. I would say, and I did give this feedback to the state employees who at the time were in charge of this program, is that it didn't have great uptake, and they were wondering, like, why aren't more people taking advantage of this? So if I'm a pediatrician and I have a kid in my office, and that kid has, like, say, failed multiple medication trials of antidepressants, and they're still really depressed, and I want to talk to somebody with more training and expertise, I would have to go to the website, and then I would have to complete an online form to request a consultation. And then at some point, maybe within, say, like the next business day or, whatever, I would get a call back. That's not super helpful to busy clinicians, because by that time the kid's out of the office. What are you going to do? How do you track them down? How do you, get in a hold of the parents? It's just not a model that is very easy to integrate into, again, a busy clinical workday. And then now, unfortunately, so I went to the website because, to be honest, I couldn't remember what the promise was as far as, like, do they call you back within 24 hours, or is it by the end of the next business day? So I was trying to find that out. And essentially nothing on the website was working. When I tried to, like, click on the link to fill out the form, that link is broken. I tried to email the people that they said were in charge, and the emails bounced. I was able to get a hold of the new person that is in charge of it, and she told me that Billings Clinic ended their partnership with MapNet and with Project Echo this fall. And they are actively working on getting the components functioning again, but they currently do not have a clinical partner for the project. So the Access Line and Project Echo are both on hold, but the Pediatric Mental Health Symposium is still happening. And there is the link to the website for the symposium. So of the three components, the symposium is still happening, the conference is still happening, but the other two, and I tried to call the Access Line and that number wasn't working either. So those are both on hold, but the mental health symposium is happening. So those are the three clinical models, but there's some other kind of concepts out there in different fields. I'm going to kind of veer away from medical field for a moment and just kind of think about other models that kind of informed my thinking. So one is this catcher in the rye analogy. So this is a quote from J.D. Salinger's book, The Catcher in the Rye. And so you can see you've got these kids playing in this rye field and, you know, they're playing ball and they're running around and they don't know that there's this big cliff. And so they're just running for the cliff and, you know, he's there trying to catch them, right? And these kids are just running and he's trying to catch them. And that's what the catcher in the rye is. So I felt like there was a lot of, you know, analogy in children's mental health. A lot of the work in children's mental health, frankly, feels like trying to be the catcher in the rye, trying to catch all the children before they run off the cliff. And this approach, you know, it's heroic, but it is also very flawed, right? It's not efficient. It's very stressful. It's exhausting. And, you know, because it relies on the catching ability of one person to prevent a child from dying. So that's not a great system. So how can we build a more resilient, more efficient, less exhausting, and ultimately stronger system, like building a fence at the edge of the field? So that's, just keep that in mind. That's catcher in the rye thinking, right? So I will be honest, this is how I felt a lot of the time when I was working at Shodair. Like I was trying to pull these kids out of the river or, you know, if the kids fell off the cliff and went into a river, like, or what have you, kids that went off the cliff, like I felt like I was just trying to catch them and keep them from dying. So there's another river or kind of analogy that is a public health concept, which upstream and downstream interventions. So the upstream interventions are like universal screening, early intervention, healthy lifestyle, you know, preventive measures. And then you have further down the river, you have patients who are symptomatic. And so you're treating the disorder, right? So in mental health, that'd be like going to therapy or outpatient psychiatry. And then you have like downstream, you have the waterfall, you have the, you know, the crash down at the bottom of the waterfall. And that's, you know, crisis, patients in crisis, they're going to the ER, you know, they're inpatient, like we're just trying to keep them from drowning. So the idea is you want to focus on the upstream interventions so that kids don't end up going over the cliff or going over the waterfall and dying. Another concept that I was thinking about as I was building this is the public school system has what's called the response to intervention. So from an educational perspective, so there's the 3 tiers. Tier 1 at the bottom, all the kids get general instruction. Tier 2, targeted interventions like tutoring, pull-out services. And then Tier 3 is the most intensive interventions, you know, and kids with IEPs, one-to-ones in special classrooms, et cetera. And they also have kind of percentages that they aim for, right? So Tier 1, the idea is that 80 to 90% of the kids will do fine with the general interventions, Tier 1. Another 5 to 15% will be successful with the moderate or targeted interventions. And then 1 to 5% would need the really intensive interventions. So that's like the goal of RTI. Let's think about that for children's mental health care, right? So Tier 1 would be universal kind of interventions or things like getting exercise, good sleep, healthy diet, social support from your friends and family. And the hope is that 80 to 90% of children will do well with that. And we've got 5 to 15% that might need more, you know, targeted interventions such as individual family therapy, OT, speech, peer support, group therapy, et cetera. And then you have your 1 to 5% that's going to need Tier 3, really significant intensive intervention like medication management, inpatient, residential, other higher levels of care. So let's think about this tier 3 and how ideally the kids that are in the tier 3 that need medication interventions would be treated, right? So there's going to be a range of complexity. And so the hope would be that you would go from low complexity up to high complexity as you go up the levels of training. I can tell you that is not the case. It is actually, it doesn't just feel, it is a lot more like this. The complexity is all over the map. So you have, these family nurse practitioners, physician's assistants, family docs that are treating kids, really, again, heroically trying to treat kids with moderate or high complexity even. And then you have child psychiatrists, because there's no real triage system right now. Basically, people take who comes to them or who, the referral ends up in their fax machine. So you do see some high complexity cases, but you also see some low and moderate complexity cases. There's no real way of triaging this currently. So I'm a very visual person. If you haven't picked that up by now, you will understand it by the end of this webinar. But if you think of a graph, right, the ideal system would be real linear, right? But currently it just feels like this scatter plot. So I want to take a minute to just kind of think about, well, why do we care? Why do complex cases need to be seen by a child psychiatrist? Like what's the difference between a child psychiatrist and, say, a nurse practitioner or a physician's assistant? This is one way of explaining the difference in training. So just clinical hours in the program, residency hours, and then total clinical hours. You can see the range. It goes from, 500 to 1,500 for nurse practitioners, 2,000 for physician's assistants, and then 15 to 16,000 for a physician. And I know there's some variability in terms of, the different programs, but regardless, there is a significant difference. This is a busy slide, I apologize, but this is specifically child psychiatry training. So what it takes to be a child psychiatrist versus, in terms of years and hours, versus a nurse practitioner. So basically, you have your 4 years of med school, and then this has 6 years, so 4 years of general psychiatry residency and 2 years of fellowship. You can combine your last year of residency with your fellowship, so it ends up being 5 years. So it's a little shorter, but it's still a very long road to become a child psychiatrist. Okay, so then now we are at the point of talking about my initiative specifically, which is the Pediatric Partnership Project. It is a collaborative initiative. It allows for relatively rapid access to a child psychiatrist. Like, I'm not saying I'm going to see kids, the same day. It is not an emergency service, but generally within a month. So evaluation, diagnosis, medication recommendations, short-term co-management of the cases. I blended elements from other models, and this fits into existing workflows. So it doesn't ask our busy clinicians to do anything outside of what they are accustomed to doing. So what are my goals? My goals are to improve access to child psychiatry for complex cases and to provide support to pediatric clinicians across the state. That's kind of short term. Then longer term, I really want to help improve the quality of pediatric mental health care, which then would reduce the burden of depression and youth suicide in Montana. So this is the project in visual form. Again, I told you I'm a visual person. I had this all like typed out on a slide, and it was just very busy, lots of words. I felt like this is a more kind of easily digestible way of looking at it. So starting at the left, we have adults, who see kids and work with kids and are around kids, whether that's, a youth church group leader, a soccer coach, a therapist, school staff, a teacher, counselor. They have a concern about a kid. They need to talk to the parent, right? I mean, the parent needs to be involved from the very beginning. So then the parent might be concerned, or the child might just tell the parent, right? Like, I'm depressed, right? So then they go to the PCP, and if it's a straightforward case, the pediatrician, of course, should manage, is very capable of managing straightforward anxiety, depression. But if it's complicated and they feel like they're in a little bit over their head, or they try a medication or two and they're not working, or the kid's having weird side effects or a weird reaction, then they can refer to a child psychiatrist. And then the child psychiatrist would evaluate the child. make diagnoses, which I can tell you is really maybe even a more powerful intervention than medication recommendations, but they do kind of go hand in hand. But getting a correct diagnosis is very, very important. And that can take anywhere from, like, say, 2 to 4 visits with the child psychiatrist, depending on the complexity and so forth. And then once that diagnostic or evaluation period is done, then the child would go back to the primary care provider, and the primary care provider would prescribe the medication based on the recommendations of the child psychiatrist, who would be a part of that visit, typically via a phone call, maybe a Zoom, but not there in the office with the kid, but joins the appointment and is available to discuss the diagnosis, medication options, etc. And after the kid has the medication prescribed, then the child psychiatrist would monitor and adjust the medications until the child was stable on a medication regimen. So that might take 3 visits, might take 5 visits. There's going to be some variability there. Once they're stable, they would go back to the primary care provider. And again, there would be a joint phone call appointment to discuss, what happened with the medication, what the medication plan is, answer any questions. And from there, the primary care provider would continue to follow the patient, with the child psychiatrist being available short term, like roughly 6 months after that, to answer questions. So that's the basic outline of the model. Like I said, it does draw on several of these other models, but it's not something that's being really widely or really used anywhere that I'm aware of. So it is a novel approach. So, if you know of kids, if you think, oh, that might be good for, a patient that I'm treating or somebody that I know, how do you refer? So our the Big River Psychology Physically, we're located in the Lion Building on Last Chance Gulch. This is our website, and really the website is the best way to contact us. There's a referral or a contact form to get put on the wait list right on the website. That's the phone number, that's the fax number. This is from the website, so it kind of explains the psychiatric medication evaluation process. It also is very clear, and I do want to be very clear that I'm not doing ongoing medication management. And so that's a big difference between what I'm doing and a typical outpatient psychiatric practice. And the reason for that is, I know that primary care doctors, would really like it if, the kids, they could just refer all of their complicated cases to a child psychiatrist and not have to, kind of worry about them anymore. But once the child psychiatrist gets full, then they can't take any other cases. And then they're really not helpful to, the community the broader community. So thus the short-term management and not ongoing medication management. And that's the presentation. So I am now available to answer any questions that people might have.
So please raise your hand in the Zoom. Dr. Zaluski, thanks for the great presentation. I had kind of a related 2 pieces of questions. Can you do telehealth? Does this work, telehealth? And then also for our local NAMI affiliates, is this something that they can reach out to their pediatricians in their community and help make the links to get this resource?
Thank you. Thank you, Matt, for those questions. And yes, absolutely. I do telehealth. I'm in the office about 2.5 days a week, and then I do telehealth the rest of the time. And since unlike my partner Hannah Nixon, who is a clinical psychologist and does neuropsych testing, for which there is kind of some literal hands-on component to the testing that she does. She has to physically see the child. Mine does not include, my evaluation does not include any of that sort of testing. And so it can be done completely, remote via Zoom telehealth. That's 100% doable. And then to your second question of, is it okay to spread the word? Absolutely. Please spread the word. That is, a big part of the purpose of doing this presentation, because, obviously, the pediatric clinics, the primary care doctors, the family nurse practitioners, partnership with them is really the entire purpose of this project. And so the more, the news can be spread that, I'm available or child psychiatry is available to help co-manage these cases, the better, the more kids we can help.
Excellent. So we just had a Representative Jen Carlson raise their hand. I think that we might have to have you type that in the chat, Representative Carlson. I'm sorry. So we'll start out with her question when she types it in the chat.
Sure.
And I do want to say, while Representative Carlson is typing that in, she did a lot of great work to help keep kids in state and get DPHHS and Shodare and Yellowstone Boys and Girls Ranch and all these other folks working together. And the results have been really amazing. So we're grateful to have Representative Carlson on the line. And let's see if there's a question yet.
Oh, it's in the Q&A.
Here we go. Representative Carlson says, thanks for thinking outside the box and using your skills to help others. She's also curious about billing and how that works. So please type them in the Q&A, everybody. Apparently I disabled the chat.
Yeah. Okay, so Q&A. Yeah, thank you for that question, Representative Carlson, and thank you for your work. And I see, Medicaid payable. Yes, I fully intend to take Medicaid. I'm having some challenges, and I don't know if there's anything that can be done about this from a legislative level. Honestly, as I said, I've been, practicing in Montana since 2007, was at Shodare for 15 years. So I am not new to this state, and obviously at Shodare took Medicaid, billed Medicaid. And when I applied, as a, under my private consultation practice, my request was initially rejected. And when I asked, and they sent me a letter and it just said, your request has been denied. And then the reason for denial was denied, parentheses, all programs. So thankfully, in parentheses. So thankfully, I have a very good insurance person that's helping me, and he called, and there was some typo or something. We're working on it, and they keep saying that it'll be done by a certain date and that they're escalating it, but it's not done yet. So that is a frustration. Medicaid, as we know, does not pay as well as private payers. I'm very committed to helping those children really want to take Medicaid. It's frustrating that they are much more difficult to work with. It was also a whole huge problem trying to use their website. It's been very time consuming, and that is a frustration I know that many clinicians in the state have with the state Medicaid program, just that it is very difficult to work with. And then, so we have to jump through all these extra hoops and then we don't get paid as well. It's a little frustrating. But yes, I am taking Medicaid. All of my consultation work is billable. I also take Blue Cross, CHIP, will be part of Medicaid, Allegiance, and Cigna. And so I will bill insurance for those. There's also, if you go to the website, you can see there is a private pay option and an expedited option if there's some urgency to it. Again, I'm not an emergency service, but there are some options to get kids seen more quickly if parents have the resources and really feel strongly that their kid needs to be seen soon. Then there are those options as well. But yes, I will be, and I am credentialed with Blue Cross Blue Shield, Allegiance, and Cigna. And really trying to get that Medicaid approval, and then I'll be billing Medicaid too. So I hope that answered your question, Representative.
Please keep typing your questions in the chat. This is great. Dr. Zaluski, while we get while we get that take, I guess what brought you to Montana as a child psychiatrist in the first place?
Sure.
What was it?
Well, so I was married with 3 kids. We were in the, Raleigh-Durham, Chapel Hill area. Um, husband is a veterinarian. Well, you didn't know that, but my husband is a veterinarian. He works in regulatory veterinary medicine. And it was just really good luck that just as my training was ending, I was looking for a job. The state vet position opened up here in Helena. His parents live in Butte and have lived there since the mid-90s. And again, he spent, some of his formative teenage years in Butte, graduated from Butte High, spent a year at Montana Tech before moving to Michigan and going to Michigan State, which is where we met. And we had visited Montana many times, and his parents were here, and we really loved Montana and loved the idea of raising our kids here. Felt like it would be a much better place to raise a family than the Triangle area. I mean, as attractive as it is, it's very crowded, overcrowded, really kind of more intense and less opportunity to really do some fun family activities outside. And just we felt like not as great of a place to raise a family. And so he got the state vet job. And then I was really just kind of like looking online and found Shodair and like cold called them and ended up, getting hired there. And so we moved to Montana and we both maintained those positions for a long time. Like I said, I was at Shodair until July of 22, and he was actually state vet right up until last July, so July of 23. So it was family, it was, raising kids, great education system. We all our kids went through Montana City and then the Helena Public Schools for high school, and been very happy with that. Outdoor lifestyles, skiing, camping, boating, etc. And then, great professional opportunities as well.
Yeah. Thank you. And I guess that highlights that you really, right now, we do have to kind of get lucky with our child psychiatrists and hope that they marry somebody from Butte. That's probably not the best system for getting child psychiatrists to our state, but thankfully it worked in this case.
Yeah, and that does also raise a good point, Matt, that, we are one of the reasons that, we are limited with child psychiatrists and, we are lower statistically than the national average is a lot of people stay where they train. They train in a certain place and like North Carolina, Chapel Hill, and then they open a practice there or they get a job there. We do thankfully have the residency program at Billings Clinic. It's kind of a small program. I think they have a maximum of 3 residents, and it just started a few years ago, but they don't have a child and adolescent fellowship. So as I said, after you do 3 or 4 years of general psychiatry training, then you need to do a 2-year fellowship before you can be eligible to be a board certified child psychiatrist. We don't have that in the state. And so, that is a limitation in terms of our pipeline of child psychiatrists. And I do see there's another question. I can see the chat. So great. I'm really glad to hear that you're here advocating, Eric, a nurse and so it says here BC PMH. I'm assuming you're well, anyway, you're here to advocate for all child and adolescent mental health, including all conditions, special interest in ADHD. Yeah, and I'm with you there. I think ADHD is a condition that, is a very common condition. And with treatment, it can, successful treatment of ADHD can be absolutely transformative for children. And so I am a big advocate of making a correct diagnosis and treating ADHD and treating it until the child is basically, asymptomatic, because we can do that between behavioral interventions and medications. I'm afraid I can't answer your question though. You say you're curious about child psychiatrists that are specialized in treating adult ADHD. So I guess I would just say child psychiatrists are specialized or, have the adequate training to treat any person throughout the lifespan, because as I said, we do 3 to 4 years of general training, and we're all of us that are to become board certified as a child psychiatrist, you first have to become board certified as a general psychiatrist. So all of us are double board certified, including myself. So I did all the training, I passed the boards to become a general psychiatrist, and then on top of that is the child psychiatry training. So any of us could see adults. And I know that there are many child psychiatrists out there that are in private practice that do see adults. But there's a good chunk of us, myself included, that really feel like, because we have the special training and because there are so few of us, that really we should focus our clinical work on children. There are more general psychiatrists in the state. I think there's roughly 50 practicing general psychiatrists. I could be wrong on that. I apologize. But I know the number is significantly larger than it is for child psychiatrists. So I think most of us are really focused on helping children, since a lot of general psychiatrists, even though they're also trained, and child psychiatry training is included in our general training, but a lot of them don't feel super comfortable treating kids, particularly younger kids or the more complex cases. So we choose to really focus on that.
Thank you. Are there any more questions? Without seeing any more questions, just really want to express our gratitude to Dr. Zaluski. We work so hard to try to help families find access to care, and when I say we, 99% of the time it's Colleen. So, but also just in our family support groups around the state, people coming together, looking to find care for their kids and struggling with that. So we're just so incredibly grateful to Dr. Zaluski for not only sharing her time, but also for sharing this model, which, boy, if we can make it work, is really exciting.
Well, thank you so much again for having me. It's really been an honor, and very excited to, I just this week, I am rolling it out, seeing patients. So I'm very excited that it is, happening. It's, I love seeing kids. I love being a child psychiatrist, and I just look forward to helping more kids and families. So by all means, if any of you guys have cases that you want to refer, hopefully the referral process is pretty straightforward. The nice thing about being in private practice is that if something isn't working, I can change it pretty quickly. So also very open to feedback.
Wonderful. Well, thank you so much, Dr. Zaluski. Thanks everybody for joining, and hope everyone has a wonderful rest of your day.
Thank you.
Bye, everyone.